You're listening to In Network, Nordic's podcast series where we explore healthcare and technology with experts from around the globe.
Hello, and welcome to the In Network podcast feature, Designing for Health. I'm Nordic's Chief Medical Officer, Dr. Karen Joswick. I recently sat down with Karen Joswick, President and CEO at Benevolence Health. We discussed CMS's TEAM program and how it differs from previous value-based care models. We also discussed leveraging digital tools for patient support and how digital apps, portals, and AI-powered decision support can drive better outcomes. Let's plug in. Welcome to the podcast, Karen Joswick from Benevolence Health Advisors. How are you today?
I'm good. Craig, how are you doing?
I am, as always, excited to talk to people like you. Where do we find you today?
So, East Coast, Delaware, the first state.
You and I met when you were trying to educate me on the TEAM program. And I had said to you, I use Teams every day. I can even chat on it. And I told you I didn't need to know anything. And you're like, no. TEAM with no S.
Yeah, we use the word team in all senses of the word. I can't tell you how many times we've approached organizations and said, so how's your team doing? And people go, they're great. What are you talking about?
Why don't you tell us a little bit about yourself? How did you get to be the person that you are now?
Let's answer about what TEAM is. TEAM is the new mandatory bundle payment program from CMS. It impacts about 25% of the hospitals across the United States. And the hospitals were selected based on their geography, or CMS has a term called CBSAs, or core-based statistical units. And so it's kind of a big deal because it's a mandatory model. And there was a little bit of betting going on about what was going to happen in Washington. Was the administration going to keep it, move forward with it? And there were a lot of naysayers that said, it's going to get wiped like everybody else, or it's not going to be mandatory. And actually, that's not true. The administration kept the TEAM model. They came out with some new proposed regulations in the last couple of weeks on it, and it's mandatory. So that means these hospitals have got to comply. I went into healthcare wanting to make a difference and a change. And I know that sounds Pollyanna, but it's true, right? Same reason why you probably went into medicine. You want to help people and make a change. And I started my career in IT and then was asked, because I understood all of this data and analytics and informatics work, could I help the operational teams implement these programs, and kind of just grew from there. And I think part of it, I had a good amount of my career in the state of Maryland, and Maryland's known for innovative models. And so I think kind of was a natural growth in that way.
Fee-for-service versus value-based care. Fee-for-service, as I understand it, is, hey, you do this thing, you get paid. Whether it turns out well, whether the patient really needed it, none of that really matters. You're going to get paid this amount of money. With value-based care, it's more like the payer, in this case, the federal government, is interested in results and paying for results. And so we've had value-based care for decades. That concept kind of started with the HMOs a gazillion years ago, I believe. And it's kind of been some fits and starts, and it's kind of going back and forth. So this is yet another attempt from the biggest payer in the United States for healthcare, the federal government, to make sure they're getting their money's worth. And as you mentioned, TEAM is not optional for the 25% of hospitals that were selected by the government. And I presume they know who they are at this point.
Gosh, I hope you do know who you are. I mean, there's a list out there. I will say, as of a couple weeks ago, we've done some outreach, and I think most hospitals know. But early on, when the list was out there, there were some that were a little surprised, like, oh, we're on the list.
So hopefully people know if they're on the list. And what do they need to do? So how is this different from other kind of value-based care? Who's being evaluated, and what kind of information do they need to present, and that kind of stuff?
Well, so first, if you don't know, check the list. So happy to send the list and where you find it. But one, check the list. And two, if you're on the list, make sure you identify who your point of contact is going to be to CMS. They want to know who they should send emails and data files. There's going to be a whole bunch of information that's going to come straight from CMS to your organization. More importantly, it's going to be a reflection point for an organization to understand their volume for these surgical procedures, understand the key service lines. So in prior bundle payment programs, they were predominantly in the orthopedic space. This program's a game changer. It includes cardiac surgery. Not a surprise, right? Think about what the federal government pays for. A lot of open heart surgeries, right? So they put CABG in there as one example. They also included some spine and some bowel surgeries. And so I think this is indicative of where the government's trying to go, is to lean into the high cost procedures, or also procedures where we know care continuum across, whether it's in skilled nursing or home health, and also where we think there's opportunities to bend the cost curve and improve quality. And boy, when you think about seniors and the cost that Medicare is underwriting, cardiac surgery seems like a great place. So do hips and knees and spines.
And I assume the idea from the government is, if this goes well, it won't be 25% of hospitals. It will be
more. Yeah.
Yeah. All right.
It's going to be more. And if it goes well, by the way, they save money. So if it goes well, it doesn't mean the hospitals make more money. There are some hospitals that are in a favorable position based on what we've kind of modeled and projected, that some hospitals, because they're already a low cost, high quality provider, they may be positioned well. There's most hospitals who are not. And so this is a haircut, right? And for some of these health systems, it's not a trim, it's a pretty big haircut. Couple $1 million a year. Craig, as you know, in this day and age, that's huge. That's FTEs. That's not just a rounding error for some of our health system partners. These are big cuts.
Maybe let's just dig in on one example. And so you had mentioned CABG. You were talking about bypass graft, so a heart bypass, which is it's a big operation. So maybe talk us through, how is it today, and then how will it be tomorrow or early of next year for those quarter of hospitals that are on the list?
Sure. Well, so CABG is a good example to talk about. There are patients who get emergent CABG, and there's not really much you can do about that, right? There are patients who are in the cath lab, they get balloon pumped and they sent to the OR, and kind of like, that's just going to run its course. Those are patients that you need a clinical pathway for. You need to be able to make sure you have data and insights, and you've got good partners to manage them across the continuum. But then there's a cohort of patients, which is most patients, right, where it is considered a scheduled routine procedure. And so those are patients that are known to you as a provider ahead of time. And so there's an expectation that, how are you engaging those patients ahead of time? Have you been educating them on what their plan is after discharge, right? We know for patients who have had this surgery that they need to be up and moving around, and they need to be exercising. And the patients who are up walking around the nursing unit in the hospital are going to be better walking around at home and going to cardiac rehab. And so there's kind of these basic tenets that good science, right? Good care we know about. But frankly, sometimes we're inconsistent in how we do it. And part of it's the patients not being educated, not being aware, not having the right support system at home. And some of it's that we are inconsistent in our clinical practice at some of our facilities, right? For lots of reasons. And so the model really is kind of pressure testing and saying, you need to be consistent, right? Reduce care variation, but also engage the patient ahead of the surgery, and also figure out what your plan is going to be after surgery, so that those patients who have a CABG then maybe go home with home health or with cardiac rehab services, and not get transferred to a skilled nursing facility for 20, 30 days, right? So really try and manage the cost of that episode and also improve the care. And we know patients who have a good destination right at home and good support system, they're going to be less likely to end up as a readmission. And I think we all know the challenges with readmission, not only around cost, but quality, and it becomes a downward spiral.
Is the government looking, how are they going to be evaluating how consistent the care is? How are they going to be evaluating what kind of prehabilitation? That's one of my favorite terms, as opposed to rehabilitation. How do they evaluate that? Or is it just, no, it's the outcomes? Like, we don't really care what you did. If you have majority of your patients don't bounce back and they're meeting certain criteria afterwards, it doesn't really matter what you did before. It sounds like it's somewhere between those two extremes.
Yeah, no, you're exactly right. So I think there is an expectation on your benchmark cost, right? It's a cost program. There's a cost savings program. So are you less expensive than your competitors in your market, right? And also, how do your outcomes fall? So there's a variety of quality measures that are included in this program, right? Some of it around patient experience, some of it's just around like all cause readmissions and all cause morbidity, mortality measure, right? So there's measures in place to look at, like you said, outcomes. But then there's the biggest stick or carrot really is the cost.
You're being evaluated about your cost compared to your competitors, compared to like kind of peer institutions in your area, it sounds like.
Yeah, your market. And the challenge with these, so CMS's word is CBSAs, those core-based statistical areas. I'll use the word market. And some organizations, their market is small. And others, it's like California, Oregon, and Washington, right? And so like they're massive geographies being compared to Sacramento when you're in Oregon may or may not be right, really fair assessments based on metropolitan. And we see this in New York, the East Coast. There's a lot in the New York, New Jersey area, et cetera.
Is this significantly different than 2 years ago with a different program for a different surgery? Like you had said earlier, orthopedic surgery tends to be the one that payers in general and the government specifically look at. But is this much different? It sounds like one of the things that sounds different to me is the fact that I'm going to be judged based on how much I bill versus my other people, either in my region or my state. Is it more of the same, or is this a particularly different kind of approach?
Yeah. So yes to both. So it's a little bit of the same, right? It's a bundled program. So we've had bundles for decades and decades in healthcare. So that part's not new. And the fact that we're including orthopedic procedures, there's been a huge shift, right, over the last 15, 20 years to move routine hips and knees out of the hospital into ambulatory care, right? Bundle those. That part's not new. What is new is that some of those other specialized procedures, like we talked about, cardiac surgery is a perfect example. And the fact that you're going to be graded, if you will, and compared against your market. So you're not beating against yourself, right? Comparing against yourself, but you're trying to beat the market, not just improve your own cost. And so that's important for lots of reasons. One, you may not know where you sit compared to your market, right? So a lot of health systems don't have good benchmarking information and data about where they sit relative to the hospital down the street. The other thing that I think is a game changer on this one is the service line engagement. Typically, in a fee-for-service world, cardiac surgery is the last area you touch for lots of obvious reasons. And so this is one that's going to really challenge health systems to have their foot kind of in both canoes, right? Like, how do you balance fee-for-service and value-based care and hope that you don't hurt either side?
One of the things that was initially confusing me, and some listeners might be confused about, with respect to needing to know how much I charge for this, my hospital charges for this procedure versus others. In general, I've always taken the simplistic view, because I'm a simplistic person, that, hey, I could charge 100,000 or I could charge $1 million for this procedure, for this admission, for this hospitalization. I'm going to get paid X number of dollars based on the DRG. And so that was always my kind of assumption. It doesn't really matter what I charge, because I can send the bill for anything. I'm just going to get what I'm going to get. But now that's actually, or maybe never, but certainly not now, that's not the case. The more I charge, even though I can charge $1 million and I'm going to get $50,000, it's going to not look great if I'm charging $1 million. And if my others in my area are charging for the same procedure, DRG, half of that, it looks bad, and it's going to be calculated as such.
Right. And I think the best way to really kind of needle down more on that is the total cost of care. So for these patients, yes, you can charge for your surgery, but are your patients going to home health, which is, maybe $1,000 of expense, versus a skilled nursing, which is maybe $25,000 for that post 30-day window? Are your patients having a bunch of extra scanning and imaging and so forth pre procedure that maybe they don't necessarily need? Is it a necessary variation in care based on the standards? So those are kind of the puts and the takes. And then to your point, yes, there's a whole internal exercise that health systems should be doing around their fixed costs. So what are you charging versus what does it cost you to actually provide those services? And that's really where I think there's a sweet spot. Organizations that are looking at their internal cost structure, how well they're managing their internal costs to provide the care, and then also looking at the care continuum. What are those patients experiencing? Are they going to skilled nursing? Are they going to home health? Are they getting extra physical therapy appointments, imaging, et cetera?
So now that we all understand what this is, sounds like step number one is to know if your hospital is in the group or not, which most people probably know by now. But sounds like there's a link that you can go to and see that list. And then step two, once you know that you're in this list, and probably it's not a bad idea for folks who aren't on the list now, given the fact that everyone might be on the list soon, is to start collecting some data. And some of the data they surely have. Surely there are other programs, other quality metrics that hospitals have to be collecting. One of the new ones is, hey, how much am I charging for this on average? And again, not just for the procedure, but for all the care that's involved versus my competitors. So they need to get that information. How do you get that information, Karen? Do you just call up, hey?
So yes and no, right? So if you're on the list and CMS has your contact information, you will eventually get claims data from CMS, but that's not going to be until later this year. So you're going to need to look at your internal assets and tools. So, depending on whether you're currently in an MSSP, so a Medicare Shared Savings ACO, maybe you already have claims data. Maybe you already have a pop health platform or a tool that you're using to do that. That's some of the hospitals for sure. There's many hospitals that frankly, they don't have those tools in play and they're on the list and they don't have access to the data. And so then there are certainly partners that have access to benchmarking where they can give you the analytics to help at least start planning to do that work. And that's some of the work that we're doing to help organizations right now is forecast where they have opportunities to focus on care redesign.
Are there other data points that folks should be collecting that you're seeing that they don't have that are unique for this program?
I'm a firm believer they really should know by those service lines which of those docs are employed versus a community-based or a partner. I think that there is an opportunity around provider engagement to really be intentional, certainly with your employed docs, but also with your community docs. Right now, if you've got, maybe a spine surgeon that's in the community, but they have privileges and they operate, but there's an opportunity to lean in around quality and engagement in this. There should definitely be conversations, right? An evaluation of who's employed, who's in your community. The same thing is true with your post-acute partners. Who are you sending these patients to? Do you have their data? Do you have a partnership? Do you have a preferred partnership? So there's definitely some internal operational areas that the organization should be evaluating as they prepare.
Is there anything that differs based on the specialty? So ortho versus cardiac versus GI, is pretty much all the same? Or are there any numbers? Oh my, for gastroenterology, you really need to know X.
Cardiac surgery is usually the most expensive, then spine kind of, follows. Some of the bowel surgeries are pretty expensive because they're usually very medically complex. If I were sitting right there in the hospital today, I would want to look at my outliers. So any patients in the last 12 to 24 months, and your med teams, right? Your med exec, they'll know that. They'll know your outliers for your cabbage. They'll be monitoring that, especially if they're involved in other registries like STS registries, any of your quality improvement work that you're doing. I'd pull all of that and really dig in deep on where you are performing right now.
Okay. And you mentioned engaging with your clinical team, especially the surgeons and proceduralists.
I enjoy working with surgeons. And maybe it's because throughout my career, I've had the ability to do that. So you just kind of learn what motivates and engages them, right? So these are typically very passionate, quality focused they truly are outcomes focused, right? They don't want a bad outcome. Nobody wants a bad outcome. And so I think if you position this program as an opportunity to really evaluate how their patients' outcomes are doing and get them the support needed, whether it's special care protocols or figuring out how your care management team can help support them for discharge planning or rehabilitation, like you talked about. I see this as a great way to engage those surgeons, maybe in ways that you haven't since maybe the service line launched or a program opened or a new surgeon came on, right? Typically, those movements are when organizations will have we just hired a new cardiac surgery. Let's look at our clinical protocols, right? Well, you should be doing that more routinely. So I think to me, this is a great opportunity to have those conversations. And then I'm a big proponent of sharing the data with them, like help them understand where they're sitting and help them be competitive, because by very nature, they're competitive. They want to know, they want to be better than the others. And so I think support them in that way is the best way to do it.
Yeah, I love that from an intentionality perspective. Physicians 100% and surgeons 1,000% are competitive, and sharing those data points with them, whether they agree that they're important or not, they want to do better than that next person. And especially if they have a negative opinion of that of someone, they're like, oh, they're beating me at this thing. I don't really, even if I don't see the value, I will not allow them to beat me at this thing. So yeah, and so engaging with the surgeons and proceduralists, that makes a ton of sense. We haven't talked about another important person in this endeavor, which is the patient. Are there things that we should be doing to engage the patient directly, or is this something that no, the clinical team and the operations folks are the ones who are the only important keys in this puzzle?
I think you know the answer to that one, right? Patients are at the center of all that we do. It's amazing how many patients don't have a good understanding of what their recovery process could look like for these procedures. I mean, even for things that are routine, like a knee, some people feel really, you have different experiences. You'll ask a patient or ask a friend, hey, and they'll say, I had no idea it was going to be so hard to get up the stairs and shower. Or I had no idea it was going to be. So I think there's an obligation, right, for us to make sure that we are really arming patients and families and their support systems better when they have these procedures. And I think that's ultimately going to get us into a better place long term around outcomes. But if you haven't invested time, energy, resources into educating patients ahead of the surgery, right? Not the emergent, right? But for the routine and scheduled, you're not in a good place long term. And if people have time to focus and plan and worry about the steps to get someone into the house or make sure they have time off those first couple days, as a supporter for their family or their loved one, it makes a big difference. And there's a lot of digital tools too, right? To be checking on your incision site and send us a picture of that, right? There's so many tools that are out there now that it's kind of like we have to be doing this, in my opinion.
For sure, we need to involve the patients. And I love the idea of kind of doing, again, that pre-check of trying to get you into the best shape you can be before the surgery, assuming that it's not urgent, of course. Can it wait a few months for you to quit smoking or for you to start exercising a little bit? If so, we know you're going to do better afterwards. And the concept of, oh, did no one ask you where your bathroom was located? Because if it is upstairs, if that's where the shower is, we're going to have a problem if there's no one there to help you. And that's going to lead potentially to you kind of failing at home and then having to go to a post-acute facility. And then that's going to cost a lot more money. And it's also not as much fun to be in a facility like that than it is to be at home. It's certainly better to be at home. So sometimes these little pieces of work, which don't cost a lot, can really bring some value. Let's talk about, you kind of teased us a little bit with some digital tools that might be helpful. One of them is using the patient portal or an app that can take a picture, that you can take a picture with your phone and send to your surgeon or your surgical team. And hey, there's really no reason for me to come in if the main question that you need to see me for is just to look at my wound. If the rest of it is just me talking to you on the phone or over a video, then that's easy. And then that saves everyone time and money. Are there other things that you've seen kind of be successful in general for patient engagement for some of these procedures?
I think there's some really interesting ones specifically around, I've seen for cardiac surgery and orthos, reminding the patient of just some of the exercises that they need to be doing. So, like, did you do these exercises kind of post-surgery? For cardiac surgery, it's, making sure that they're doing their IS, incentive spirometry, and they're coughing, right? Just some of these basic things, like, have you done this? And those in the early days, we know that makes a big difference for folks that have had, orthopedic procedures. It's obviously watching all of these surgical sites, but exercising and moving and, did you get up and move around? And so I think that there are gentle reminders and app tools, right, that are ingrained into folks' phones that it can either go to the patient or to their supporter. Did mom get up today? And I think that we've certainly grown and evolved so much. I mean, we have reminders to my Amazon is going to run out of paper towels, and I get a reminder, hey, Karen, do you want to order more paper towels? Right. As opposed to, why can't we do this with some of our surgicals? And I think we're seeing it, but it's not embedded in just, this is good care. Again, it goes back to that clinical pathway. Like, this is just good care.
Yeah. And that good care concept, I think really resonates with clinicians, especially. We don't really need to talk about team versus another program. It's just, no, this it doesn't really matter what your insurance is. It doesn't matter how you're paying for this. These are things that we do for all of our patients who are undergoing these procedures.
And oh, by the way, some of the other commercial insurance companies are having conversations. If they haven't already, they're looking at this to say, well, why would it matter if it's Medicare or a commercial plan? Why wouldn't we want you to save money for our patients too? So I think I've heard from some health systems that we're doing work with that their commercial plan has said, we'd like to talk about doing bundles for these patients too. So I don't think it's that far for health systems to see a knock on the door about this one.
It makes complete sense. And again, I typically say that my job when I've been the CMIO before, with one foot in the IT world and one foot in the clinical world, is to make it easy to do the right thing. The hard part is figuring out what the right thing is. In this case, we're being told, and I think there's some consensus about what the right thing is, and then we just need to enable it. Pivoting off of that, making it easy to do the right thing. How do we do that in the tool that most clinicians use all day, which is the electronic health record? So I know I've just opened up a whole can of worms. Are there clinical decision support tools, or do we need to rethink how we use clinical decision support for some of this? Have you seen any organizations kind of successfully figure this out?
It's interesting. You said clinical decision support, and I think probably everyone listening just like got a chill, right? I mean, think about, we spent the last 20 years implementing these rule-based algorithms, if this, then this, right? And these alerts that we have out to folks. And now we're moving towards more AI tools where we're trying to really learn from prior decisions and to make more informed and more enabled, decision support. And so when I think about how clinical decision support can evolve with value-based care, we really need clinical decision support tools that help us manage some of the outliers and the ones that are, if you will, where we have blind spots. And that's not always been the case for CDS or, the decision support tools. It's the 80% that fits in the square peg, right? We'll tell you to do this. And so you think about the patients who, we'll pick on the cardiac surgery patients since that's our theme today that we've been talking about. What about the patients who maybe don't have a good support system, or they don't have transportation, or they are not going to be able to get food at home, and we need to worry about Meals on Wheels, or we need to worry about follow-up transportation to home, whatever it may be. I think that's where there's power in some of the new models and some of the new testing that's happening in their EMR around AI, clinical decision support. And I think this is where, as informatics leaders, we've got to lean in and kind of harness that, because it's the 20% that we keep missing that can be the challenge.
We definitely focus on the easy part. Why? Because we're humans, and that's easier to do that. And so, but your point's well taken in that I found if I really, really want to irritate a physician, I should remind them to do something that they were just about to do.
Yeah.
They really dislike that. That's a big bummer. And so kind of making sure that clinical decision support helps, whether it's physician who's seeing the patient pre-op or in a follow-up appointment, or it's a more of kind of a population health perspective. Are there any tips or obvious things that we should be doing from a population health, from dealing with multiple patients for team or for other programs like it that you typically see folks aren't doing?
I think that there is a tremendous opportunity to kind of keep your head down and lean in on some of the projects that a lot of health systems are already doing. And those are data standardization. Right now, so many healthcare organizations are receiving claims data, maybe from a payer or from the federal government, and they just don't know what to do with it. You've got to be able to integrate claims and clinical data together. And if you don't have a roadmap and a plan for that, you're going to be behind. You're just going to be behind. It doesn't matter what model it is. So that's something that's really important. If you don't have a way to give performance dashboards, right, back to your providers, sometimes we would lovingly call them provider scorecards, right? So if you don't have those things in play, and that they're actually being used, right? So it's not enough to have a dashboard, but are they actually being used in a collaborative sense and driving outcomes? You need to look at that, because that kind of data is what's ultimately we see the people who are top tier, top performers in these value-based care programs. It's because they have the data right in front of them. And they are, just moving right along and using those data insights. And then, Craig, the last one I would say is, it goes back to the claims a little bit. If you don't have a collaborative relationship with your payer, so CMS or your commercial payers, and what I mean by that is there's some sort of data sharing, right? So think most health systems work with 10, 15 different insurance companies, right? Payers. And guess how many file formats are sent to them? Exactly the number of payers. Like, nobody's using a consistent file format. Nobody's using consistent tools or definitions. And so the onus, unfortunately, is sitting on the health system. And there are some tools that have started to improve that. But if you don't have a strategy to take all of this external data in, normalize it, and then share it with your clinicians and your operators, it's very hard to blindly perform well without those insights.
Let me just jump up and down on that last word you said, insights. So it's not the data that I'm interested in. It's what am I doing wrong, or what am I not doing right that these insights can bring to me, so that I can say, you're right. I never asked about stairs, or no one on my team asked about stairs, or they did. And the patient said, yeah, I have stairs. And then that was recorded dutifully in the electronic health record. And then no one did anything with that information. And we were setting ourselves up for failure. So yeah, that plan to actually take data and move it into insights and then make actions out of those. That's where a lot of people don't design their processes well. This has been great, Karen. Thank you so much. We always end with the same question, which is, we're talking about design and intentionality. Is there something that you use that's so well designed that you feel joy whenever you interact with it? Anything like that in your life?
I've got kids, probably like most folks, and I have to track them all down, and they are at everywhere. So I really appreciate some of the calendaring options to just share with them. But also there's an app called Life 360 where you can track your kids. And so, like, the teenage driver that's driving fast and so forth. So I think for me, on a personal level, the ability to monitor and know what's going on with my kids in this tech-enabled world and still be close to them is a good place.
It was very much more complicated than now to know where people needed to be. And so I accept your calendar option. But I think there is some joy in that. It's a lack of stress, right? Where's my kid? He was supposed to have called me. He didn't call me. Let me track his location. He's still at the baseball field or at the high school, where I know that he's okay because he's obviously been paying some more attention to the sports than to answering my texts.
For me, the calendar growing up was the calendar on the wall of the kitchen. And my signal to come home was the street lights turning on when it was dark. So it's a very different world to imagine all of the parenting and so forth. So yeah, that's my season of life right now.
I love it. Well, thank you again. It's been a pleasure, and look forward to seeing how team works out for the 25% lucky participants starting next year.
Thanks, Craig. A pleasure. Always great talking with you.
Thanks for tuning in. We hope you enjoyed today's episode. For more on Karen, follow her on LinkedIn at linkedin.com/Karen-Joswick or at benevolencehealthadvisors.com. Check back for more episodes of Designing for Health wherever you listen to podcasts or on nordicglobal.com. Till next time, we'll see you in network. If you enjoyed this episode, please leave us a 5-star rating and a review. This helps others find the podcast as well.